Hello and good afternoon, everyone. Thank you so much for joining us. Welcome to today's webinar presentation, Primary Care Provider's Guide to Hepatitis C Burden in California. I'm Alice Nelsner, and I'm the CEO for the San Bernardino County Medical Society. We are really just the conduit today for today's session, along with our partner CHAISR, or Community Health Association for the Inland Southern Region. This event is being brought to us by the San Bernardino County Department of Public Health. We sure appreciate this collaboration with them, as well as the Keck School of Medicine at University of Southern California, or USC, in Los Angeles. I'm going to introduce our presenter, but first we're going to go over just a couple of quick items that I want to share with you as we go along. If you have questions for our presenter, please feel free to enter them into the chat, and we will probably wait till the end of the presentation to answer the questions unless she would like to see something that she wants to answer right away, which is totally up to her. But go ahead and enter those in chat, and we can also take raise hand feature at the end of the presentation. So at this time, we'd like to welcome Norah Terrault, MD, MPH. Dr. Norah Terrault is a transplant hepatologist, the Neil Kaplowitz Professor of Medicine and Chief of Gastrointestinal and Liver Diseases Division at the Keck School of Medicine at the University of Southern California in Los Angeles. Dr. Terrault has focused her clinical and research activities on viral hepatitis and fatty liver disease, with specific focus on patients with cirrhosis and liver transplant recipients. In addition to multiple clinical trials related to preventing and treating chronic hepatitis, viral hepatitis, and fatty liver, Dr. Terrault has been PI on multiple NIH-funded studies, including the current NIH-supported HBV Clinical Research Network, HBRN, Non-Alcoholic Steatohepatitis Clinical Research Network, NISH-CRN, and Liver Cirrhosis Network, LCN. She has authored over 400 peer-reviewed manuscripts, editorials, invited reviews, as well as U.S. national guidelines for treatment of chronic hepatitis B and C and reproductive health. Dr. Terrault is currently serving as president of the AASLD. Dr. Terrault, warm welcome to you, and we'll turn it over to you now.
Great. Well, thank you very much for that lovely introduction, and I really, truly am delighted to be here today. I was sharing with the group that, hang on a minute, I just want to make sure I'm getting this correct. Can you see my slides? There we go. Okay. You know, the timeliness of this is, I just can't overstate it. Earlier this morning, I was doing a congressional briefing on HCV elimination in response to the new President Biden budget, which actually includes for the first time a line item around HCV elimination, where they're proposing to really rapidly accelerate the goals of elimination through improved point of care testing, through providing access to drug therapies using a Netflix model, and bolstering implementation. And that largely means implementation in the primary care setting. So it's a very, very exciting time. I mean, it's in the budget, it has to be passed, and we have to get sort of support for it. But just to give you a sense that there's a lot of momentum right now around HCV diagnosis and treatment, and everyone in this field recognizes that the primary care provider is going to play a very, very essential role as we move forward towards this elimination agenda. So just that's a backdrop. So these are my disclosures. None are relevant really to today's talk. So I start out was by, you know, the whole idea of elimination actually was something put forward by the WHO. And when they talk about elimination of viral hepatitis, they are referring to both hepatitis B and C. And when they say elimination, what they're referring to is seeing a reduction in new infections by 90% by 2030, and to see a reduction in liver-related mortality by 65%. So that's the goals of elimination. And here in the United States, we are not at all on track to make these goals by 2030. In fact, our number of new infections are on the rise, as opposed to seeing a decline to 90%. by 90%. We have seen improvements in terms of liver-related mortality, but we still have not met these benchmarks. And in fact, if you map out kind of our current pace with which we're moving towards elimination, it's been said that we're unlikely to meet the elimination goals even by 2050 without a significant change in our strategy. And this is why the President Biden plan is so timely, so important if we're going to get closer to meeting these elimination goals by 2030. Now, a little bit about California. So we don't have great data around how many Californians are affected with hepatitis C. But if we just base it on our population size and what we know to be the prevalence of hepatitis C, we would estimate that there's probably around 40 million Californians who are infected, representing about 15% of all the HCV infected individuals in the United States. Now that's an approximation. It might be 10, but it's still a big number. And what's interesting and what I've always been quite fascinated by is while we have very large urban centers, and I practice in one of them, there are a lot of rural counties. People don't realize, I think, when they think of California, just how many of Californians are living in rural areas or suburban areas where they don't have access to specialty care. And so that in itself has presented a major barrier in terms of individuals getting appropriate care of their hepatitis C. By appropriate, I mean access to treatment and cure, because it's been largely in the hands of specialists in years prior to this. And this really emphasizes the importance of having primary care be the people who are doing screening and treatment, because they're in the populations in these more rural or suburban settings. Okay, so you all know that the reason that this all became kind of possible is with the advent of direct acting antivirals, or DAAs. It's really a remarkable sort of scientific achievement. When I started as a hepatologist back in the late 1990s, Hep C was just sort of discovered, really. And it had been discovered in like the early 90s, and it was sort of just becoming a disease we knew about. And to think that by 2014, we had actually developed a cure. That's a remarkable kind of rapid evolution of therapeutics. With our current DAAs, what you can tell a patient is that with a single course of treatment, their chance of cure is 95%. So the vast majority of patients need one course of treatment that's 8 to 12 weeks in duration. Remarkable. We're not near there for hepatitis B, but hepatitis C, this is a really very high rate of cure with single course of cure therapy. And that's really what's prompted this kind of push towards getting more patients to cure. But we know that we're sort of falling short. So we have these highly effective drugs, but when the CDC did a sort of a vital signs look at things in 2022, around this time last year, they showed that actually the number of patients that have been treated has been on the decline. So even though we've got these remarkable drugs and we know all these individuals exist that need to be treated, the number of people actually being treated through pharmacy claims data has been on the decline. And when they looked at sort of timely HCV treatment by insurance type, that's shown on the right, you can see that in the Medicaid population, that really only 1 out of 4 at best is receiving treatment who is known to be infected, right? So this is a huge gap between known to be infected and not getting treatment. And then there's another big gap, which is they don't even know they're infected. But just to say that even among those known to be infected, we're not doing a stellar job in terms of getting access to treatment. And we know that this is like, there's lots of reasons for this. And so in the strategic plan that's been laid out in the President Biden's budget and through Dr. Francis Collins' plan is to really acknowledge that there is many barriers. We've got to attack them all. The first is a lack of awareness, with 40% of people who are infected with hepatitis C not knowing they're infected. The second is that diagnosis is a two-step process. You do an antibody test first, and then you do an RNA test. That in itself adds complexity. There's the cost of treatment. You know, currently it's around $23,000 per cure, as it were. That's much less than when we started, where it was more than $100,000 per cure. So it's come down, but it's still got like a sticker shock to it. So that's an issue. The issue that treatment is not yet sort of integrated well into primary care. There's a lot that we have to do to sort of facilitate that. And then finally, where hepatitis C is, is in populations that are more difficult to reach, uninsured, persons who inject drugs, those that are involved in the justice system. Those are where we know there are high prevalence of hepatitis C, and that can be a more difficult group to get into care. So these are all barriers, but all of them can be overcome. And one of the key things is really around the idea of simplifying the whole care cascade. So shown on the top, I'll just kind of quickly walk you through the many steps that are involved in the past and how we're moving towards trying to do a simpler approach, which is on the bottom. And key to that simpler approach is co-localization of testing, staging, and treatment. As a theme I'm going to come back to many times in the talk today, and why I'm so pleased to be able to talk to you to try to encourage you to become these HCV champions, as it were. So on the top is the way that we sort of have historically done HCV care. So you can see at the beginning, the screening and the diagnosis of hepatitis C is typically done in primary care. We start with an antibody test, we do a HCV RNA test, and then we refer them to the specialist. And then you can see along the specialist cascade of care, there's many visits were involved in the past. Visit to confirm they were infected and to get additional testing done to determine stage. Then we had to get sort of pharmacy approval. And all of that led to, many, many steps and patients getting lost along the way. And you can see that, if you go from the screening through to cure, it's like 10 steps, really. Now what we want to do is co-localize this so that it's all happening in one place and it's happening with more rapidity, with more rapidness, right? So you can do screening and diagnostics. We're really striving to have that be kind of a one-stop shop where you do a antibody test and reflex to getting RNA testing done, that the pre-treatment workup is simplified and doable by primary care. Treatment gets prescribed without hiccups, hopefully, and then you move on to having somebody who's in the cured bucket. So really trying to streamline that whole process. And key to that, of course, is building capacity for doing that co-localization of care within primary care. Certainly what I hear, and I am very aware of, is that primary care physicians have so much already on their plates, right? So adding one more disease that we're going to be saying, we would like you to be taking these patients and taking them through the whole cascade of their journey. We have to talk about this and then bring into play the supports to make sure that that capacity building can occur. And one of the ways that I just want you to be aware of, and some of you may already have participated, is that USC has something called Project Echo. This is for free. I think I must be on a timer here. These are free, and it's a hub and spoke model. So the idea is we have a virtual clinic every other Thursday from 12 to 1. The hub is myself and my colleagues that are kind of the experts in HCV, but our goal is to take individuals who are primary care that are joining us virtually and turning them into experts over time. We use our virtual clinics to do a short didactic where we cover a topic usually in the first 20 minutes or so. And then we use the rest of our hour for the spokes, our primary care providers, to present cases. And it's a case-based learning where through that exchange of them presenting the case and us discussing the case and sort of the nuances around how we make a decision about how do we do staging, how do we think about the treatment, what are the nuances in this particular patient. Hopefully the entire group gets expert and grows over time. And this is something that you are very, welcome to join. It's just a matter of like joining in. It's really all of it is really meant to be a way to support primary care providers to have support to do HCV treatment. And I'm always available by email or by text if there's an urgent question, but the idea is to be your backup and your sort of that place for you to gain expertise as HCV treaters. Okay, so in the time that I have, what I'm going to do is give you just a bit of a crash course on becoming an HCV champion. And I'm going to focus on really trying to convey to you the simplicity of this, recognizing that a lot of this might be new information for some, but to sort of say, I view this as sort of, you need to develop 3 sets of skills. You got to understand the screening. I'm going to sort of try to share with you how you can easily stage the disease using non-invasive tests, and then we'll talk a little bit about treatment. And I think what I can say is that the first patient that is treated is often the one that requires a lot more kind of, it seems like it's complex, but once you've done one, I think it really does become simpler over time. And I can share with you that what I've heard from my primary care providers is there's just nothing like having someone that you kind of take through this journey and deliver a cure. And you do it very consistently, 95% of the time. Okay, so let's talk about screening. I've mentioned it several times that one of the main issues is that somewhere between 40 to 50% of patients who have hepatitis C are unaware. This is a study that we did using the NHANES data. And in this study, what they did is they took all these patients, they tested them all to see if they had hepatitis C and B, and then they asked them, did you know you had hep C? And 50% of the time they said, yes, I already knew I had hep C. But 50% of the time, patients that turned out to be positive didn't know they were infected, right? So it's just showing that gap. And there's been a lot of promotion within really at the population base to try to highlight that we need to find individuals. This is just one campaign from the World Hepatitis Alliance. They put out a kind of Find the Missing Millions campaign a year or two ago. And I always really liked this concept that we got to find them if we're going to cure them. Now, you know that the US Preventive Task Force, Preventive Services and Task Force put out a recommendation around screening, and that now it's changed, right? So we used to do kind of risk-based screening, then we did baby boomer screening, and now we just screen every adult, right? So the new recommendation around screening is that every adult aged 18 to 79 should be screened once in their lifetime. So I think thinking about how do you implement that in a healthcare system to get that one-time screening done, that's the only way we're going to find the missing millions. And then the guidance also says that you could consider, screening beyond those bookends, lower than 18 years or higher than 79, if you have somebody who's at risk for infection, meaning somebody who, maybe has a history of past injection drug use, for example, or blood transfusion. Emphasized also in the screening guidance is the importance of us communicating to patients that, of course, screening is voluntary, but I think also letting patients know that the reason we're screening is because it can be an asymptomatic condition. You won't know you're infected unless you get tested, and that we have something curative. Like that's a message that has to go hand in hand with this opportunity for screening. I mean, this is just to say that the reason that the guidance changed, the guidelines around screening changed, was because our epidemiology has changed. And the baby boomers, which are shown in this figure, remain a group where we see a high prevalence of hepatitis C cases. These are individuals who were infected decades ago, most of them when they were in their 20s and 30s. But not just that, but there's definitely that group has been well recognized to be at risk for hepatitis C. But where we're seeing the new infections are really in the millennials, where this is really related to the opioid and other substance use epidemic that we're all facing. And I know that you are all very familiar with this, but this is where the new infections were coming. And so this is the group that really was being missed with prior screening. And so now the recommendation just to screen across the age spectrum is really to help us to identify those who were infected decades ago, but also the new infections. All right, so I've highlighted, and I'm hoping this is really very familiar to you, but the screening test of choice is an antibody test, but and it's a very sensitive and specific test, so it's very, very good test for screening. But if you have somebody who's antibody positive, you have to confirm if they have virus. So the antibody says they've been exposed to the virus, they made an antibody response, but to determine if they're chronically infected, you need to test for virus. So you do an HCV viral load, a nucleic acid test. And the reason that we need to do that confirmatory testing is that actually people can spontaneously clear their hepatitis C. And the younger they are, the more likely they are to actually clear it spontaneously. So some patients, you'll test them, they'll be antibody positive. They clearly have a risk factor for hepatitis C, but when you evaluate them, their HCV RNA is negative, which means they cleared it without treatment. So you need to do it. And in order to make it simpler for patients, we're trying to encourage those that are using labs. If you can encourage the lab to do reflex testing, that's the best, right? Because then the patient goes once to the lab, they get the antibody test done. If the antibody test is positive, the lab reflexively then orders an HCV RNA. So a lot of the labs are now doing that. Quest does that, LabCorp does it, but sometimes you have to talk to your own local lab to say, this is actually the strategy we'd like to adopt as a way to ensure that we're making the diagnosis concurrent with doing the screening, right? All right. Okay, so that's the screening. Now your antibody positive, HCV RNA positive patients, the next step would be to say, what is their stage of disease? And and by stage, I'm really just saying, do they have cirrhosis? Yes or no? That's what we care about. We don't care, we have these staging systems for fibrosis that go from 0 to 4, but in the end, you just want to know, do they have cirrhosis or do they not? And so all of our non-invasive tests are focused on just that decision. Cirrhosis, no decision. No cirrhosis, no cirrhosis. And the reason we care is because those with cirrhosis, they derive a lot of benefit from cure, but they still need a different kind of monitoring after cure. Because individuals who have cirrhosis at the time they're cured remain at risk for progression of liver disease. It's markedly reduced. For example, their risk for liver cancer goes down by 70%, but it's not zero. So you need to continue to monitor them for cancer after cure. And some of them, if they have a second liver disease, like they're drinking alcohol or they have metabolic fatty liver disease, can still progress. So we want to know about that group that has cirrhosis because they need to be counseled differently. They need to be given guidance around surveillance for the complications of cirrhosis, even though the cure has significantly reduced their risk. So that's why we go cirrhosis, no cirrhosis. Okay. So how do you kind of get to that? First is history. I think you're trying to get an idea of, is it somebody who, really only has a risk factor for acquisition? They're 20 years old. They recently used injection drugs, for example. I'm not really worried that patient has cirrhosis, right? They're a recent infection, not likely. So the history helps. And understanding likely how they got their infection. So you can kind of pinpoint in your mind, when did they likely get infected? Are they infected for a few years or a few decades, right? Remember too, that patients can have other factors that would make them more likely to have cirrhosis. So the Hep C is one factor, but if they have alcohol use, if they have HIV co-infection, if they have fatty liver, as I was suggesting, those patients progress more rapidly. So even with relatively short duration of disease, they can have cirrhosis. And then of course, clinically, you're going to look for anybody who's got any symptoms that might suggest decompensation, but those are really quite rare. I want to highlight 2 laboratory clues for cirrhosis. And of course, if their liver synthetic function is abnormal, such as like their albumin is low or their bilirubin's elevated, I'm sure all of you would say, okay, that I'm worried about that patient. They likely have cirrhosis, even more advanced liver disease. But the earlier clues to cirrhosis are platelet count and the AST-ALT ratio. So any patient who's got a platelet count under 150K, you should be thinking, they may have cirrhosis, because cirrhosis leads to portal hypertension and causes the spleen to enlarge slightly. And so their platelet count starts to go down due to sequestration. So it's a very good clue, actually. And you're going to see when we look at the non-invasive test that we use that platelet count as part of the way that we assess whether someone has cirrhosis. And then the other clue is the AST to ALT ratio. So in somebody who has chronic hepatitis C but does not have cirrhosis, the ALT is greater than AST. But as they move towards cirrhosis, that ratio flips and their AST becomes higher than their AST. So that's another clue. So these get kind of put together into non-invasive ways that we assess for cirrhosis, no cirrhosis. So I'm going to share with you blood tests, and it very specifically something called APRI and FIB4, because they're based on platelet count, AST, ALT, as we just talked about, and age. But there is a commercially available test of fibrosis too, called FibroTest or FibroSure. You can order that through Quest or LabCorp. But honestly, you can do APRI and FIB4, which cost you nothing. And so I think doing FibroSure is just added cost without a lot of added benefit, but it exists and can be a tool if you want to use it. And then obviously liver imaging can be helpful. And I tend to get an ultrasound on my hepatitis C infected patients. And I'm using the ultrasound to see if there's any clues that the patient may have cirrhosis, such as a nodular liver edge, splenomegaly, intra-abdominal varices. But oftentimes the ultrasound is normal, and that's okay. But I want to make you aware of a new tool called vibration controlled transient elastography, which measures liver stiffness. And increasingly, that tool is becoming available on ultrasound machines, like the Siemens machine. Now, in some places, they offer elastography as part of the ultrasound testing. So you should be aware of elastography as a tool you can use to help identify patients with cirrhosis. So first, let's start with the simple things that you can get with routine labs. So APRI stands for AST to platelet ratio index, and you can see the formula there. We use the AST value divided by the upper limit of normal times 100 divided by the platelets. It gives you a score. If the score is over 2, they have cirrhosis with high degree of specificity. The FIB4 also uses platelet count and AST, but adds age and also uses the ALT, so the ratio is there. Here you get a different number, but here, if the value of your calculated FIB4 is greater than 3.25, then that's also highly likely the patient has cirrhosis. So for example, I gave you a patient here whose AST is 89, their platelet count 150, and they're 58 years of age. And you can see I calculated here both the APRI and the FIB4. Now you would say, the APRI doesn't quite meet the 2 to get to cirrhosis, but it's close, it's 1.7. But the FIB4 definitely puts this person into the likely has cirrhosis. So from my point of view, you've done your duty. You now have identified that this is a patient who likely has cirrhosis. I would get an ultrasound to just kind of, again, look to see if there's any other radiological signs, but these tests alone would tell you the patient likely has cirrhosis. Now, the calculators, you don't have to memorize these formulas. There's calculators that are available online. So just put in APRI or FIB4, they come up all the time. I put one of them at the bottom there. Okay. And then elastography. So how does the elastography work? It's like it uses an ultrasound-like probe, but the probe sort of pulses over the liver and is measuring liver stiffness. So there's a shear wave through the liver, and that shear wave correlates with the amount of inflammation and scarring in the liver. There's different size probes depending on whether you have somebody who's obese or not. And there's a little bit of operator dependency, but generally it doesn't take very long to become very good at doing fibroscans. And these give you scores as well. And if you have a score, in this case, over 12.5, then that's consistent with cirrhosis. So again, a non-invasive way. So we no longer do biopsies in patients with hepatitis C to figure out what stage they're at. We're using these non-invasive tests of FIB4 and APRI. And in my clinic where I have a elastography available routinely, we do it every patient. But just know that if you don't have it available now, it's likely to become available in the future because they're adopting them to the routine ultrasounds. That's what I'm seeing. So just be aware. Okay, so, as I mentioned, your goal here is to say cirrhosis, no cirrhosis. So if you have most of your tools are telling you the patient likely has cirrhosis, then you treat the patient as if they have cirrhosis. And it's important, I want to just emphasize that you do all of this staging before you put them on treatment, okay? And the reason is that all those cutoffs that I gave you, whether it's an APRI cutoff of over 2, a FIB4 greater than 3.25, transient elastography greater than 12.5, all those numbers are based on people with chronic infection, not who are cured. The numbers would be different if they're cured. Okay, so just important that you stage them and make sure you know, do they have cirrhosis, yes or no, before you put them on treatment. And then for those that have cirrhosis, you have to go one step further and you have to ask yourself, do they have enough cirrhosis that I actually should be starting to think about referral to a specialist because they might need a transplant or something more. And to do that, you should calculate the Child-Pugh score and something called MELD-NA. MELD stands for Model of End-Stage Liver Disease. These are all based on laboratory results, and in the case of Child-Pugh score, also if they have ascites or encephalopathy. This is only relevant if you identify somebody with cirrhosis. Then you got to go one step further and say, do they have compensated cirrhosis, in which case I can take over the care and keep going, versus do they have enough disease that makes it more risky for me to do treatment and I should engage a specialist? And that's using these two scores. Okay. I'm going to just check the chat here, see how I'm doing on time. Okay. I'm going to follow up now with the treatment. Now, this is really just to give you a flavor of treatment, okay? I don't want to, I'm giving you a lot of information today, but I also want to sort of convey that it's pretty simple. And I always say to, when I'm giving this talk, that I think Hep C treatment is simpler than managing diabetes or hypertension, right? You have so many things to manage there when you think about it, and you got to do all these adjustments and keep changing, and Hep C is easy, right? I'm going to suggest to you, you just need to know 2 drugs. And knowing those 2 drugs, you can largely treat every patient you see. And regardless of what drug we go with, they're all oral, they're all a once-day dosing, and they're all a short course of 8 to 12 weeks. And the safety, I'm not going to say more about it, but they're very safe. It's really a rare patient where they complain of a side effect where you have to maybe think about making a change. I can't remember the last patient that happened. Okay. Some core concepts. I've already highlighted a few of them. It's curative. So once you treat them, we do an assessment, and I'll show you 12 weeks after they're finished. And if they're still HCV RNA negative, then they're cured. So it is a 1-course curative treatment. It doesn't come back. It doesn't reactivate. You know, it does none of that. It's curative. 8 to 12 weeks, well-tolerated. Side effects, these are the ones that you'll hear about. And most patients, I just counsel them to keep going, because they tend to get better after the first week. Adherence is important. So readiness for treatment is an important aspect of treating patients. You know, sometimes if you're treating individuals who are actively still using drugs, you can treat them, of course, during that time, but you have to be sure they're ready for it and they're being well supported to be adherent. And then I didn't spend a lot of time on this, but all of the DAAs carry a risk that if the patient happens to have hepatitis B as well, that you can reactivate the hepatitis B. So you do need to have some measures around monitoring for that, but that's only in patients who have hepatitis B also. So how do we define cured? This is just mapping out the typical course of a patient who's going through treatment. So you start out at the beginning of treatment. Most patients have viral loads that are in the millions. And then usually within the first 4 weeks of treatment, their viral load becomes undetectable or very low. And then they keep going, and they either do an 8 or a 12-week treatment, depending on the treatment course you choose for them. Then you stop the drug at the end of that 8 or 12-week course, and then you check them again for HCV RNA 12 weeks after they've completed the treatment. And if that viral load is still undetectable, that's called sustained virological response at week 12, or SVR 12, they're cured and you are done. Now, I wouldn't be a good virologist if I didn't show you the little map of the drugs, but it's just to point out that there are a total of 4 drug classes that are used. And a bit like HIV, where we put drug classes together to get effective viral suppression, in hepatitis C, we combine drug classes to get effective cure. So all of the drugs that are approved have at least 2 drug classes in them, sometimes 3. So just to make that point. And the drug classes are NS3, 4A protease inhibitors, NS5A inhibitors, nucleoside analogs, and they're of 2 different kinds. So those are really all you need to know. Here's really the list of all the medications that are approved for hepatitis C, and really don't really spend any time looking at this other than for me to say, people get very, kind of confused by the names. I always like to give them a little bit of a cheat sheet. So, there are 3 classes. The NS3, 4A protease inhibitors are all Previrs, Previrs, protease inhibitors. All of the NS5B inhibitors are Buvirs, and all of the NS5A inhibitors are Asvirs in these drug combinations. I'm going to emphasize to you that there's only 2 drugs that I think you need to know. One of them is Epclusa, which is Sivosbuvir and Valpatisvir. It's an NS5B and NS5A combination. And the other is Mavorite, which is Glecaprevir and Berprentisvir. So different combo that we're using, different classes. But those two are the ones that are recommended under the current simplified approach to treatment. And the reason they're recommended over some of the others is that they work regardless of genotype. Okay, so some of the other ones on this list, like Harvoni, Zepatir, they are only effective against certain types of hepatitis C, whereas Epclusa and Mavorite, they are effective against all types of hepatitis C. And you'll also notice there's only one drug in this list that has a drug from each of the three classes. And it's voxilatravir, sofosbuvir, valpatisvir. It's a bit of a mouthful. We call it Sofvalvox. This is a drug that also works against all types of hepatitis C, but it's used as our rescue therapy. This is the therapy we use when they failed their first course. So we have a first course that we're going to use one of these two agents. And if they're not successful, if they happen to be in that 5% that isn't cured with their first course, we would treat them with the triplet. And then at the bottom are drugs that used to be available for hepatitis C, but have been discontinued because there are better ones. This is just to highlight what I just said, which is if you talk about the subtypes of virus, there's 6 different genotypes of hepatitis C. It's a test that you can obtain, and some of the insurers still require you to obtain the genotype. But the reason that the experts now recommend just using these 2 drugs is because you can see they work against all of the genotypes. And for that reason, you don't need to do a genotype anymore. And in fact, the simplified approach suggests you don't need to do genotype. I want to highlight that there's a very good resource if you sort of want to know where everything about Hep C treatment lies. It's under the AASLD IDS A guidance. I'm just showing you a snapshot of that website, but it's really has everything. It has treating in special populations. It has the treatment by genotypes. It has the treatment by whether they have cirrhosis, and probably has more details than you want, but it's a good resource, and I just want to make sure you're aware of it. Now, in the last few minutes, I'm just going to give you a little sense of the drugs. I mentioned to you that you're really only going to need to do 2 that I really want you to be aware of. So glucapavir proprentasvir, its trade name is Mavorite. Again, works against all the genotypes, so that's why we like it. It can be given to 8 or 12 weeks, but actually the recommended treatment now is 8 weeks. So it's very attractive, short course of 8 weeks. You don't need to do any dose adjustments if they have cirrhosis. You don't need to do any dose adjustments if they have renal impairment. So it's really very straightforward. And shown at the bottom is what it looks like. There's 3 tablets that they take once a day for 8 weeks. So that's Mavorite. The other one is sofosbuvir valpatisvir, or Epclusa. So this is also works for all genotypes. Here, the treatment duration is 12 weeks. There's no 8-week option here, just 12. Again, no concerns if they have cirrhosis, no concerns if they have renal disease. They work very well. There is one caveat you need to be aware of in terms of drug-drug interactions, and that amiodarone co-administration will lead to bradycardia, so it's contraindicated. And I'll share with you shortly that there are other drug-drug interactions you need to be aware of for each of these drugs. But just to make that point, that's an important one to call out. And this one is just 1 pill a day. You can see it here, 1 pill a day for 12 weeks. So those are the 2 options that we have available. And then for the patient that fails that first course, I mentioned to you before, you would use Sofvalvox. This is also given for 12 weeks. Occasionally we use it with ribavirin, but I'm not going there today. That's a more complex patient. This one is a treatment in which you can use it in patients who have cirrhosis, but not if they have more advanced cirrhosis. Again, no adjustment for renal impairment, but there is this warning about the bradycardia because it includes sofosbuvir. It's a 1 pill a day. So 1 pill a day for 12 weeks. And the patients are usually given 1 month supply for all of these medications. So for the one that's 8 weeks, they're going to have to refill once. For the Sovaldi, so with the Epclusa and with Vosevi, this medication, they'll have to refill twice. So how do you ultimately choose between, say, the two that I recommended? There's GP, glycophobia preventasphere, and sovosbuvir valpattosvir. So how do you pick between the two? Well, in the end, I'm going to tell you that it mostly comes down to drug-drug interactions, because they do differ in terms of the drug-drug interactions. But another factor that might be important is the insurance sometimes has a preference for which drug they prefer, and that relates to how they negotiated cost. And sometimes I think it matters to the patient of a number of pills and whether they want to do 8 versus 12. Most people want to do a shorter course, but some people have already a big pill burden. So 3 pills more every day is sometimes something that needs to be considered. So this is just to say that, you know, these are the 2 drugs that you need to be aware of. This is the ones that I want you to get comfortable with: GP and soft-val, one for 8 weeks, one for 12. There's also some requirements for them to be taken with or without food. So that's something else you have to keep in mind. You would base your selection based on drug-drug interactions, patient preference, insurance preference. And this is the other bonus is that there's no monitoring on treatment. You start treatment and then you don't need to do any monitoring until you're checking to see if they're cured. So that's really also simplified things. Okay. So who's eligible for kind of this very simplified approach? Well, pretty much all the patients you're going to see. Most of them are patients who have chronic hepatitis C. If most of them will not have cirrhosis, and most of them will not have previously been treated. So they're perfectly suited for this simplified approach that I just shared with you using those 2 drugs. Even those with cirrhosis can potentially be eligible, but there's a few more steps in terms of evaluating those patients with cirrhosis. But many of the patients you're going to see will not have cirrhosis, will not have been treated before, so they fall into this large bucket of individuals that can be treated with a very simplified approach. I'm going to skip this one. And this is just a snapshot to say there are drug-drug interactions. So the 2 drug combinations I've been sharing with you is soft-val here at the second from the second column, and then glycophobia preventasphere, which is on the far right. And it's just to make the point that there are drug-drug interactions you need to be aware of. And sometimes that will influence your choice of one drug over another, because you're trying to like, okay, I don't want to have to change the other medication. Let me just choose one where there's no drug-drug interaction. So very, very important. This is the one sort of important stuff. And there's a very, very good website, and I'm showing you a snapshot of that website. It's called the Liverpool Hep Interactions website. It's a great spot. You just put in on the left which hep drugs you're thinking of using, and then you put into the other side all of the co-medications the patient's on, and it generates a table for you and says yay or nay on the drug interaction. So it allows you to very quickly figure out, you know, what you might want to choose. So this is on my computer is kind of one that I have bookmarked because I go to it often. Don't try to memorize the drug-drug interactions, just, you know, use this as a resource. Okay, so my last slide. I know I've given you a lot of information, but what I hope I've conveyed is that really, I know you are the ones that do the screening. Recognize that with this idea of screening every adult once is important to find the missing millions. I hope that I've kind of conveyed that staging of disease, cirrhosis, no cirrhosis, can be easily accomplished with non-invasive tests. Most of the patients you're going to see, because they're newly diagnosed, are going to be treatment naive, and many will not have cirrhosis. You may see cirrhosis, and even those are within your wheelhouse to treat with some support. The treatment algorithms have been simplified to really learning 2 drug combinations, GP and soft-val. One is for 8 weeks, one is for 12 weeks, but these are pan-genotypic, so you can use them across all manner of patients. The one little kind of important thing is check for drug-drug interactions and then ensure that you've got good adherence. But otherwise, this is something that's, you've got to admit, easier to manage than diabetes and hypertension, right? All right, great. So this is my last slide. I always like to show this. I borrowed it many years ago. Somebody made this cartoon, and it says, it took us 25 years to bring him to his knees. Now let's finish him off. And this cartoon came out in 2014, which is when the first all oral DAAs became available. And so I added in the primary care providers, which are down at the bottom there. are going to be the ones that finish him off. That's my belief. Thank you very much.
Wow. Thank you so much, Dr. Terrault. That was unbelievable. And I'm sure that especially for our providers on here, that was just information they can use and that they will continue to refer to. We do have a few questions, and our Deputy Public Health Officer, Dr. Sharon Wang, would like to make a quick comment, if that is all right. So Dr. Wang, we'd like to introduce you right now to make some comments.
Thank you, Dr. Terrault. That was wonderful. And I do want to get to the questions, but I do want to say, part of our county effort to help eliminate Hep C is we are advocating for opt-out testing in all urgent care and ER settings. So opt-out testing includes Hep C and the reflex to viral RNA for confirmation. So for the listeners out there, if you have influence over that, that's something that we really want to advocate, the opt-out testing, including HIV, syphilis, and Hep C. We have our outreach mobile teams that we take the Hep C, HIV, syphilis screening to you. So that's also something that we do. We have 2 mobile vans that do go out to all ends of our county to do screening. And then lastly, we do help with linkage to care. If you have patients that are diagnosed, reach out to us. We can assist with linkage to care. And we can bring Dr. Terrault to you to help manage, to help teach you how to manage primary care, Hep C in a primary care setting. And then lastly, we are working with some big HMO to try to eliminate that need to refer to specialists for GI and ID referral. Some of the HMOs are still requiring that, and so we're hoping to work with them to remove one more barrier. Thank you.
Thank you so much, Dr. Wang. That was wonderful. Well, we do have a few questions, so I'm going to turn it over to my colleague now, Ms. Soteria Cobb, who can go back. Looks like we have about 4 or 5 questions here. So Soteria, I'll turn it over to you.
Hi there. The first question is the protocol for adolescents and children.
Yes. Okay. Oh, awesome question, actually. Okay. I'm not a pediatrician, but we have approval of drugs down to age of 3. So there are treatments available. There are age limits with each of the drugs. So it depends on where they've studied them, right? But for example, Soft-Val, for example, the one that I spoke about here, which is the 1 pill a day for 12 weeks, is approved in children as well. So you have access to treatment for adolescents and children, which is curative also, but it goes down, the lowest age is 3 years of age. I just don't, there is a little nuance between the 2 drugs. I just can't remember what their ages are. One is to 12, one's to 3, but you have access, and you have access to a pan-genotypic drug regimen for sure. Which is encouraging, right? Because there's a lot of stigma around Hep C. And I think one of the important things is, initiating treatment in that population. They don't have cirrhosis, right? We're not worried about them, getting into liver complications, but the stigma of being infected as a child and adolescent can really, could potentially impair their interaction. So I think it's such an important thing that we can offer treatment and cure to that group as well.
Perfect. And the next one is, there are many ESRD or transplant patients with Hep C. Any different strategies for them?
For end-stage renal disease patients, the answer is no. There used to be a lot of barriers around doing ESRD because sofosbuvir hadn't been studied yet in renal patients, but that now has been studied, so they're no different. Transplant patients are, and the reason is transplant patients, we don't recommend using a short duration treatment of 8 weeks in transplant patients, and there's a small risk of rejection when they clear their Hep C. So it really should be done in the context of the transplant team monitoring the patient to be sure that there's no risk for rejection during or in the early phase of cure, because they rapidly clear virus, and actually immunologically that sort of leads to them being actually at higher risk for rejection. So they're a little bit more complicated. I wouldn't do those without support of the transplant team, but ESRD, treat them like any other patient.
Perfect. And the next one is, for staging prior to treatment, if APRI, FIB4 are very low, do you still recommend FibroScan/US, especially in resources resource limited areas?
No, I don't. It's a great question. So I think where ultrasound and transient elastography are actually most helpful is when you have them where they're right on the edge, or when the FIB4 and the APRI kind of give you different answers, which sometimes they do, right? One says there's cirrhosis and one says they're not, and you're kind of like, oh, then you need like a tiebreaker. And then I think ultrasound transient elastography can be helpful there. But if both of them say the patient has low risk, you're done.
Perfect. The next one is, I saw that all of the Hep C drugs interact with, is it statins? Statins. What if the patients have a heart disease and need to be on statins?
Yeah. So there's two options. One is the statin, which is the least, has the least effect, is pravastatin. But generally, if they have heart disease, that's not the statin of choice. But one option is if they're on a statin for a reason where you could switch to pravastatin, that's one option. The second is, with GP, for example, treatment is only 8 weeks. So sometimes we stop the statin if we can for 8 weeks and then just resume it after. And then the third is if they really just had an MI and you want them on their statin, is to do a dose reduction. So that's the alternative. I usually review it with my pharmacist and they usually half the dose and then just monitor. So it's possible, but it needs attention, right?
Very good. And the next one is, are the POC Hep C tests widely available? I've been having trouble getting Hep C screening with my Medicare patients that I want to screen, but have no abnormal labs as Medicare won't pay.
Yeah. So I'll tell you that in the, a big part of this national strategy around HCV elimination is focused on point of care testing. The answer is that it's hard to get point of care testing. It's hard to get them paid for. And we're lacking a point of care test for HCV RNA, which is what we want, right? You want to do a point of care test where you can not only test for antibody, but if they're viremic as well. Mm-hmm. And what's interesting is there is, COVID, we developed diagnostic tests very rapidly, right? And so there are really a lot of discussion now about really tapping into that same platform to really push now diagnostics for hepatitis C. So we don't have them today, but I'm very optimistic around HCV RNA point of care testing being available in the near future.
Very good. Oh, there's one more. It says, well, you've got a lot of praises for great lecture, so great job. The other one says, thank you. This is really informative information. I'm an OB MFM. Can I treat my pregnant patients yet?
Great question.
If not, shout out to all those PCPs who will eradicate disease prior to pregnancy.
That's exact. Well, that is the strategy, is that we're not recommending treatment during pregnancy, but I'll let you know that it's being studied, right? So we think the drugs are actually safe, but they haven't done the studies. There's been only one phase 2 study using soft Harvoni, soft lidiposphere. So we're not recommending it in practice, but this is probably to be an area to evolve over time. So stay tuned. But for the moment, the focus on, treat them before they get pregnant. And then the other thing is, if you identify them as being infected during pregnancy, is to not lose that opportunity to treat them right after. You can't do it during breastfeeding, but after that, you can treat them and kind of treat them before they get pregnant a second time, right? So there is a need to link those HCV infected pregnant women to a provider who can do the treatment when it's the right time. It's a great question.
Perfect.
Why don't we have Dr. Sakara mention his comment to the group verbally about alternatives to statins?
Oh, just to remind everyone that, or if you haven't seen it, there's a new non-statin drug, bempedoic acid, that's been released that achieves as an equal reduction in all of your lipids, specifically your cholesterol and LDL cholesterol. So that might be a good alternative. Dr. Terrault, great presentation, and you've really simplified it. And I'm an older internist as well, and it used to be, diagnose Hep C, and then you wait like 3 months to get to see a hepatologist. But and it's certainly very doable now. As a public health physician, though, what I see is the sticking point in this is that second step, it's cirrhosis or not. And a couple of questions. One, do you know what's the percentage dropout in that step? Because it seems to be the sticky step. Screening we can get done, and then once we've got to get compliance for the patient to actually be diagnosed, and relative to that, if they do or not, could we start patients on therapy and then do the cirrhosis tests? Or
no, that wouldn't work, because then the tests just are impossible to interpret, right? Because we didn't study them that way. But really, let me come back to this. In resource constrained areas, or in situations where patients just won't come back if you ask them to do like an ultrasound. And I hear this in my echo clinic, like getting an ultrasound is a deal. Like that's a deal.
That's the tough part.
Right? So just use FIB4 and APRI. Honestly, they're fine, and in resource, it's much better you use those, make your decisions, and move on to treatment rather than risk losing the patient trying to get an ultrasound done. Now, just be, attentive though, that if you have somebody that the FIB4 and APRI say they do have cirrhosis, just that you've got it in your head that, okay, this patient's going to need ongoing monitoring. You still want to get that ultrasound at some point, right? But I wouldn't hold up treatment. Okay.
It's great to hear. Yeah. Do most health plans like Medicare cover
they do
medications?
Yeah.
Great.
They do. They may have a preference, but they do. But it's still, what I'm going to say though, is I think the paperwork, to get approvals is still more burdensome than it needs to be. Right. And I think that can be tough on clinics where filling out kind of the required paperwork to get the drugs is a burden, but it's getting easier. And in California, we have a law that took away the requirement for pre-approval, right? So it is getting more streamlined. And I'm hearing from my, frontline folks that are treating in very resource constrained areas that it is much simpler now than it used to be.
And do the drug manufacturers, do they give, can they?
They do. There's a patient assistance program that they have as well.
And can they give a full course treatment pack?
Yeah, that would be great.
That
came up on the call today. They were saying that that's something that has to change as well. They should just give the whole course, right?
Yeah.
I completely agree. They do not. And there's some advocacy has to occur, I think, to change that, but that would be important as well.
Going back to Andrea's comment about Medicare not covering the test if patient has totally normal tests.
That doesn't make any sense, right? We have a guidance that says that every adult should be tested. We have a law in California that says if patients have asked to be tested for B or C, they should be offered testing. Like we have the most the best opportunity in California. But, it's a matter of sometimes you just can't fight the fight, right? It's kind of annoying, but truthfully, that's just not right. It's just not right. There's just nothing to support that claim.
So this is
normal liver tests just are not a clue as to whether somebody has hepatitis C.
I just dealt with LabCorp today. A provider ordered an acute hepatitis panel for the Hep C screening as under preventive care, and they wouldn't cover it for Medicare. I tried to look in their problem profile to see what I could use. I live in Needles, but I was helping somebody in Hesperia, and it was a LabCorp in Hesperia that would not cover the Hep C screening. It was ordered under an acute hepatitis panel. Is there something?
Yes, I was just going to say that might be the problem, right? Because acute serologies, you only would order those if the AST and ALT are very elevated, right? So I think that might be the issue, right? They probably require that to get an acute panel done. So I would if you could just order an anti-HCV without having to do the acute panel, you would get it.
And I also, being from Needles, we get most of our labs through the hospital here, and it's a very small hospital, so they're on the ICD-10 codes, and it's impossible to get screening codes for Medicare to pay for Hep C.
Okay.
So
well,
I'm having that issue out here.
okay.
And
No,
I've had
no,
it for
thank you
years.
for this. You know, this is my other job. I put on my AASLD hat now and I'll say, okay, advocacy, we got to start working on this because these are like ridiculous barriers to me, right? Just like, okay, so thank you for that information. I'll try to, let me do a little digging and work with my advocacy group, see what we can learn and see if we can move the dial. It's ridiculous.
Thank you so very much for that amazing presentation and insight and for some discussion as well. That was really helpful and comprehensive. So we appreciate you bringing this to us so much, Dr. Terrault, and thank you, Dr. Wang and Dr. Sakura for Department of Public Health making this possible. And to our partner, Community Health Association Inland Southern Region, as well as IWIN, along with SBCMS. We want to thank everyone so much. We will send out slides as well as recording. Dr. Terrault has graciously agreed to allow us to send out her slides. So we'll be sharing that with you very soon. We hope everyone has a fantastic rest of your week. And we want to remind you to tune in next Wednesday, the 22nd of March, for our COVID update from Dr. Sakura and members of his team. We're going to take a look back and talk about what have we learned and where are we headed with COVID. So we're really looking forward to that next in our series of COVID presentations. So anyway, thank you so much, everyone. We appreciate seeing you all. Have a fabulous rest of your week.
Thank you.
Bye-bye.
Thank you, everyone. Thank you.
Thanks, Dr. Terrault.
Thanks, Dr. Terrault.